Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on HIV post-exposure prophylaxis, featuring Dr. Michelle Collins-Ogle, who is an assistant professor of pediatrics in the Division of Pediatric Infectious Diseases and Pediatric and Adolescent HIV at Children's Hospital at Montefiore and the Pediatric Hospital of Albert Einstein College of Medicine in the Bronx, New York. She'll take us through a case study of a person with a possible HIV exposure and will explore the latest data and recommendations for choosing an ART regimen for post-exposure prophylaxis. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Collins-Ogle.
My name is Michelle Collins-Ogle. I am an assistant professor of pediatrics in the Division of Pediatric Infectious Diseases, Pediatric and Adolescent HIV at Children's Hospital at Montefiore, and that's the Pediatric Hospital of Albert Einstein. I'm also on faculty at Albert Einstein School of Medicine as well. Today, we're going to have a conversation about key decisions in HIV, post-exposure prophylaxis, and we're going to also talk about pre-exposure prophylaxis in this context as well. We're going to start off by talking about an individual case, and this is a case that we're often seeing when people are requesting PEP. So we're going to have a conversation about this case and put it in the context of why PEP is important. First case is a 22-year-old man who has sex with men. He reports having high-risk sexual exposure within the past 48 hours. And I like to just pause for a second and discuss the conversation around high risk. I usually don't use that term when I'm talking to my patients. That can appear to be judgmental, can appear that we're saying that somehow they're more at risk of HIV than other men who have sex with men who may not have the same behaviors. So I speak in terms of just risk. So any condomless sex that they may be having or sex that they're having with unknown partners, I just like to remind them that they are at risk. So maybe make sure your choice of words don't appear to be judgmental when you're talking with someone about post-exposure prophylaxis. In this case, he reports having condomless sex with a partner of unknown HIV status. And this was sort of an online hookup. So he didn't know very much about this individual at all. So on his initial presentation, after discussion about what his risk factors may be for HIV exposure, we also discussed what the initial evaluation for post-exposure prophylaxis would involve. So you'll see on the right side of the screen are the baseline laboratory findings for this individual at the time that he presented for PEP. And just a few things that I want to call your attention to. One is the HIV antigen antibody test. It's important that you don't just use the rapid test alone, although you should use that at the time that they present to your office to make sure that you know at the time they're seeing you that they do not have HIV. But remember that antigen antibody test is going to pick up early antigen and antibody if the person's been recently exposed. So make sure that you have both your rapid test and your fourth generation HIV test as well. You may also want to include in that an HIV RNA. And in this individual's case, it was undetectable or non-detected HIV RNA. And the other thing I think is important to notice is the hepatitis B status. You definitely want to make sure you know if this individual is immune or not, and if they have antibodies. And it's always good to know what their vaccination status is at the time. And again, as a sidebar to this, if they are not immune and they haven't been vaccinated, or they've been vaccinated in the past and they have waning immunity, please revaccinate the patient and explain to them the importance of having antibodies to HPV. So make sure you know the hepatitis B status, because that will have some impact on your regimen that you use. And the other thing that's important, of course, is to note the liver enzymes as well. So his baseline labs look really good, and there's no contraindication for PEP in this individual. So this slide It seems a little busy, but it's not. And this is an algorithm for evaluation and treatment of potential non-occupational HIV exposures. And if you look to the left of this slide, you'll see where it says substantial risk for HIV acquisition, and it lists the exposure and exposure sources, potential exposure. And then there's also with, so exposure of the various body sites with blood, semen, vaginal secretions, rectal secretions, breast milk, or any body fluid that is visibly contaminated is someone that we want to evaluate for potential non-occupational HIV exposure. So the important thing to note on this slide is how long ago was the person potentially exposed? And in our individual's case, it was 48 hours. So if it's less than 72 hours, then we're going to go to the left side of this algorithm, of this flow chart, rather, to make the decision about this person actually being on PEP. So if it's been more than the 72 hours since exposure, you want to make sure that you explain to the individual about the data and that there's no advantage to using PEP if it's been more than 72 hours. And again, it won't be recommended. If we go back to our person who's actually a candidate for PEP, you'll see there's two types of people that we're looking at in this individual case, whether the HIV status was known or whether the HIV status was unknown. And then the individual in this case, that was an unknown, a person with an unknown HIV status, there's a potential source of HIV exposure. So in that case, again, depending on what type of interaction they had, what type of intercourse, if they participated in actual body fluid exchange, it's very important to note that. So please make sure you individualize that on a case-by-case basis. If the HIV status is known of the individual, then PEP is recommended. And this is if the individual is positive, but I want to also put the caveat to that in the setting of U equals U, that may not necessarily be the case. And if the person is potentially exposed, if they know the individual, or if they know that the individual is undetectable, then you may not necessarily need to do PEP depending on what type of exposure it may have been. So I would just caution to make sure you pay attention to that caveat. Oftentimes in these cases, like in this particular case, the source person status was unknown, and this was also an online hookup. So if you don't know the individual, if the individual is not well known, whether we know if they're undetectable or not, if they are living with HIV, we do want to make sure that the person understands that they do have a risk for HIV acquisition and that we recommend PEP in those cases. So when we look at our preferred and alternative 28-day ART regimens for non-occupational PEP, we see there's two different recommendations for preferred as well as alternative. And I also want to make a caveat here to the 28-day ART regimens. Oftentimes, patients are going to be on their regimen for 30 days, and that's because that's the way it's prescribed. The pharmacies don't open medication for 28 days. They will ask you to prescribe a 30-day supply, and so that's what we do as well in all cases. So if the individuals are 13 years of age or older, and this is including pregnant women, and they have normal renal function, which is defined as a creatinine clearance of greater than 60 milliliters per minute, then we have a preferred regimen that is going to consist of 3 ARVs. And those regimens are one is FTC TDF plus DTG, which is given once daily, or FTC TDF given with raltegravir twice daily. So that is the one caveat to doing raltegravir versus dolutegravir. And then if for some reason you are unable to use the preferred regimen, there's a 3-drug ARV alternative regimen that can be used, and that would be FTC TDF in combination with darunavir and ritonavir given once daily. So this is just some data to review on an open label study that's looking at once daily combination pill of bictegravir, FTC, and TAF for PEP And again, this study reflects daily use of bictegravir FTC and TAF 28 days as a PEP regimen. As you can see on the left of the slide, the demographic breakdown is there for your review. And then if we look at the characteristics on the right side of the slide, again, we'll see that the different types of potential exposure that may be considered significant exposure for HIV are listed there as well. And the most common exposure in this study that was reviewed was receptive anal sex. Also, receptive or insertive oral sex were common as well. And again, these are common risk factors for potential exposure to HIV that we see in practice, primarily in men who have sex with men. So if we look at the once daily bictegravir FTC TAF as a PEP regimen and tolerability, you can see that it was tolerated very well when compared to other medications that are used in PEP regimens. So primarily just to pay attention to, commonly people that take PEP, their common adverse events include GI upset. So if we look at diarrhea or loose stool or actually nausea, vomiting for GI upset with bictegravir FTC and TAF, you'll see that it's very low actually compared to the other antiretrovirals that are used in PEP regimens. Also important is headache. And it's something that I actually document as either a positive or a negative finding when I see people at their 30-day PEP visit to see how well they tolerated that particular regimen. And as you see here, the combination bictegravir FTC TAF headache is very low, and especially compared to other ARV regimens for PEP as well. So overall, we see that the combination of bictegravir FTC TAF in a one-pill regimen was well tolerated in this study. And then if we look at completion rates of once daily bictegravir FTC TAF PEP and a PEP regimen as used as a PEP regimen, again, compared to historical ARVs that are used, bictegravir FTC TAF completed as prescribed 90%, which is very, very impressive and very encouraging. And I do want to compare that. If you look over to the raltegravir, 57% completed. The biggest concern there is raltegravir is given twice daily. So what often happens in these particular cases are that people either forget to take raltegravir altogether or only take one dose instead of two, which is recommended in that regimen. And then if you look at that compared with the other once daily regimen that I mentioned as well for PEP, alafenamide, cobicistat, in combination with FTC TAF in a once daily, in a formulation of one pill given once daily, you'll see that the completion rate there is 71%. So overall, the once daily, the pills that are co-formulated and given once daily have the best completion rates when we look at the PEP regimens. And then, of course, in the bictegravir FTC TAF, there were no individuals that stopped or modified their regimen. And again, very low number of individuals that were lost to follow-up. So this regimen, again, looks to be very well tolerated. Completion rates are high. And also in this study, no participants that received bictegravir FTC TAF in combination taken once daily seroconverted or became HIV positive. So recommended laboratory monitoring for PEP, you'll see here, I just want to call your attention to baseline. Of course, we make sure, as we discussed earlier, the most important things to note is that their fourth generation antigen antibody test is negative, that their Hep B and C serology, again, are negative. If they're positive, you are going to consider alternative regimens for PEP. And again, you want to make sure that patients understand the importance of having antibodies to HBV. And then, of course, we're going to do your STI testing according to the type of sex the individual has. And if it is a male or female, you may decide to do more extensive or less extensive STI testing. And for women, cis women, please make sure that you do a pregnancy test and you document that they are either pregnant or not at the time that they are to start PEP. The other part that I'd like to just call your attention to on this slide is what to do at the 4 to 6 week post-exposure. Generally, we like to see people at 4 weeks, right at the end of their PEP regimen. And at that time, of course, you're going to repeat the HIV testing. So antigen antibody test at that time is really important. And the caveat to your 4-week follow-up will be the need for STI testing. Many individuals will not engage in any type of sexual encounters while they're on PEP. And if they tell you that they haven't been sexually active and they don't feel that they need to be screened, you don't really need to feel that those types of screenings need to be repeated at the 4-week visit. Also, make sure you check their serum creatinine just to make sure they didn't have any problems while taking the PEP. I also like to let people know if there were any problems that once they come off of the medication, that if there were any abnormalities, they should become normal and not to worry about those. And it's not a reason for them not to have taken PEP when you talk to them at baseline. And then, of course, at the 90-day and 6 months post-exposure follow-ups, HIV testing is important to do, and along with HBV or HCV serology. And again, STI testing as needed, depending on what the individual's lifestyle is or what their sexual encounters have been at each of those visits. So once a person has completed their 30-day PEP course, I often have the conversation with them about PrEP. And I actually have that conversation with them at the onset of PEP so they can think about it over the course of the 30 days while they're taking the PEP. Some individuals, and I'm sure you all have experienced, they come in for PEP more than once. They may be individuals who do not use condoms consistently or consistently have sexual encounters with individuals who either they don't know their HIV status or, again, they engage in online hookups with anonymous partners. So those individuals, you want to start having that conversation with them at the onset to give them time to think about it. A lot of times that's the best time to have that conversation because they're really scared that they may have been exposed to HIV. And this is a good way to have the conversation with them about PrEP and kind of alleviating, those anxieties around having condomless sex. So this is a conversation that you will have with someone who has ongoing risk for HIV exposure. And again, I start talking with them about this at the time of PEP initiation so that they have time to think about it. And of course, when they come for their 30-day PEP follow-up, you want to make sure, as we discussed, that you document an HIV negative status with the 4th generation and also an HIV-1 RNA, which is important if you're going to start PrEP. For PrEP options, I think where this audience knows the current available PrEP options, and that'll be FTC TDF, given in a once daily combination pill, and the indications you see there. Most importantly is to make sure that their creatinine clearance is greater than 60 milliliters per minute. And then, of course, FTC TAF and a combination given once daily. And this is the indications here, again, for creatinine clearance that's above 30 milliliters per minute and not for persons at risk for acquiring HIV infection from receptive vaginal sex. And then also newly approved is our cabotegravir IM injection given every 2 months. And the indications here are for adults and adolescents at risk for sexually acquiring HIV, in the case of adolescents, to make sure that they weigh at least 35 kilos. So now I'd like for you to hear from the individual who actually was on PEP and made the decision to take PrEP to decrease his risk for HIV exposure.
My first experience with PrEP was I had an exposure. Well, I wasn't sure if I had an exposure. The person I had sex with, we started out with condoms, but as we progressed, it was just like, we stopped using the condoms, and I was kind of like really uncomfortable afterwards. So I made a couple of phone calls, and I did a couple of Google search first, and I decided to make an appointment, and I went right in, and that's how I got introduced to PrEP. When they explained to me, they're like, you have to take it for 30 days, and at the end of my 30 days is when I was introduced to taking PrEP. My decision to take PrEP following the PEP process was totally based on the fact that I'm sexually active, and like I feel like in today's society, and not everyone is honest about, their status, and, it's more positive now than, let's say, 10 years ago. So like, as a sexually active person, I'm like, you know what, doctor, let's just go ahead and do this, because you never know, like it could be that the condom breaks or anything like that. So to be more secured, I would feel much more comfortable starting the PrEP regimen.
So the key take-home points from this presentation is to understand the current guidelines that are recommended for HIV post-exposure prophylaxis, and that your window must be less than 72 hours of an exposure. And that's very important and really important to explain to individuals who come seeking PEP. The regimens that are listed in the slide that we discussed today are dolutegravir plus FTC TDF. That's 2 pills given once daily. And then raltegravir, which is given twice daily in combination with once a day FTC TDF. So again, also I'd like to mention that as discussed earlier, and we saw the data for earlier, the tolerability and completion rate of a single tablet formulation of bictegravir, cobicistat, FTC, and TDF used once daily as a very acceptable preferred regimen for PEP. And then we have data to support the use of bictegravir, FTC TAP as a single tablet regimen for post-exposure prophylaxis. This is exciting, looks good, looks very well tolerated, very high completion rates of at least 90%. And the nice thing about this is for patients are also able to use this formulation if they have a creatinine clearance that may be a little lower than 60 milliliters per minute as well. So this is a very, very exciting new regimen that hopefully we'll be able to use soon or have as a tool in our regimen for PEP. And then following your PEP course, make sure that PrEP is considered if indicated. And again, key take-home point with that is to have that conversation when they come in at baseline for PEP. It gives them time to think about it while they're still very much concerned about their exposure to HIV. And also it helps alleviate this cyclic anxiety that many young people have that have condomless sex, particularly men who have sex with men. This, can relieve that anxiety. So I have this conversation with them and have it early and often so that they understand that they have ongoing risk and that they can minimize that ongoing risk by just going straight to PrEP. And remember, just to review his case, he's a 22-year-old man who has sex with men, and he reports having a potential exposure to HIV within the past 48 hours. Remember, again, I like to just use the term he's at risk, not necessarily whether the risk is high or low, risk or risk. Risk is risk, rather. So he is at risk for a potential exposure to HIV. He has condomless sex. And in this particular case, he had condomless sex with an unknown partner who he also had an unknown HIV serostatus. And then again, there's just a review of the characteristic lab findings. And important to note is beyond having a negative 4th generation HIV antibody test and a negative RNA, just make sure that you document their hepatitis B serostatus as well as HCV. And again, liver enzymes in this case are normal, and you want to make sure you document that as well. The current guidelines preferred for PEP include TDF FTC with either dolutegravir, which is given once daily, or raltegravir, which would have to be given twice daily. They're both acceptable. And again, I will include in here, that wasn't part of this particular assessment, but to include in there a once daily co-formulated pill of bictegravir, cobicistat, FTC, and TDF. Very well tolerated, high rate of completion, also an acceptable preferred formulation for PEP. So go online for more CCO activities on key decisions in HIV care. You can see the medical minutes and podcasts with expert faculty, clinical thought commentaries from physicians and patients, and then patient education sheets to print and share, which patients really, really appreciate, and they enjoy it when we give them information that they can actually digest and be better informed about decision making. And then you see the link there for clinicaloptions.com/HIV for more information. Thank you very much for your attention today.
Thank you to Dr. Collins-Ogle, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.